welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Hey, welcome to Brain Chat. Hey, everybody, it's Dr. Mitzi, the nerdy neurologist, and I am so excited to be here with you guys on another wonderful Monday, having a conversation about one of my favorite topics, the brain. And I've got two amazing neurologists here with me today. But before we get started, we first want to thank our sponsor, the National MS Society, for sponsoring Brain Chat, as well as the Joy Life Foundation. Also, for all of you who are logging in, just type into the chat. Let us know where you're logging in from. I bid you greetings from Atlanta, Georgia. And it is getting a little less hot here, so I'm very excited about that. So we're ready for fall, and I hope that everyone is staying cool as the end of the summer and the beginning of the fall and all the season gets started. All right, so let's get right into this conversation. This one is going to be a good one, and I know I say that every episode, but I really, really mean it today. So I've got two amazing neurologists with me today, two of my super friends, as I like to say. Dr. Tirsham Guyang, she is an associate professor of neurology at the Ohio State, and she focuses on neuroimmunology, including MS and other neuroinflammatory diseases. And I also have Dr. Alex Porter Humphrey, who is a neuro-oncologist and professor of neurology at the Mayo Clinic. Welcome to Brain Chat.
Thank you.
Thank you. Yeah.
All right. Sorry. I know I've got the energy, guys. I'm doing a little extra, but that's okay. Forgive me. I'm really excited about this conversation because this is one that I think is really important. And sometimes we don't really think about the crossover between, oncology and autoimmune diseases, but really it's like this, the immune system gone wild. So we'll get a little bit more into the details, but first, let's start with you, Dr. Guyang. Introduce yourself and tell us a little bit about how you got interested in neurology, in particular in autoimmune neurologic CNS diseases.
Yeah, absolutely. I am super excited to be here again. And it's always a very fun place to be and just to talk with you and your audience. So as Dr. Williams said, I'm Tia Yang. I am at the Ohio State University, where I take care of patients with MS and conditions that look like MS. When I went into medical school, I did not think that I was going to be a neurologist. I just fell in love with neurology during medical school and decided to do a residency. During my residency, started seeing a few MS neuroimmunology patients, got super interested, started working and shadowing one of the neuroimmunologists. And, I ended up doing my fellowship. And basically that's most of what I do now. I take care of patients with MS and conditions that look very similar to MS. And I love doing what I do. I love engaging with patients. I also do a little bit of clinical research, and I also do a little bit of education. So I'm the fellowship director, so I also train other people to learn how to take care of patients with MS.
That's more than a little bit of education. Dr. Guyang, fellowship director is a lot of education. And you also do a lot of research, and you also educate a lot about, the importance of diversity in clinical trials. You and I have done lots of work focused on that. So I really appreciate you kind of helping with that translation, between the bench work, as well as coming to the real world where we can really help patients. All right. We will pass it on to you, Dr. Porter Humphrey. Tell us a little bit about how you got into neuro-oncology.
Well, thank you. And I'm just thrilled, Mitzi. Dr. Williams has such a beautiful voice. And me, in my ignorance at a conference, said, you know what? You have such a beautiful voice. You should really have a podcast. And she said, well, let me tell you something, Dr. Porter. So what a joy it is to be invited today. And thank you so much for hosting this platform that is such an important avenue for education, which leads to empowerment, and of course is all wrapped in advocacy. So I'm just excited to be here, thrilled to see how your career has blossomed and the impact you're making all over the country. And of course, this reaches, I'm sure, internationally as well. As you mentioned, my name is Dr. Alex Porter Humphrey. I am a neurologist, neuro-oncologist. And when I entered medical school, I actually thought I wanted to be a neurosurgeon. And I thought I wanted to be a neurosurgeon from a very young age, because when I was probably in elementary school, there was a neurosurgeon who'd come to international acclaim for having separated twins conjoined at the brain. His name is Dr. Ben Carson. He does other things now, but at that time, that was the first introduction I had to the idea of neuroscience and brain health. And he had written a book called The Gifted Hands, and my dad brought it home and said, you should read this. And in the pages of The Gifted Hands, I found myself inspired and really connected with an individual whose curiosity exceeded his immediate surroundings. And so at that point in time, I said, I'm going to be a neurosurgeon. And that was really the end of the creativity around how I was going to influence and impact medicine. I was only all too disappointed when I entered medical school and signed up for neurosurgery as my first rotation. And I was so excited. I got to scrub in. The surgeon welcomed me to join next to him at the OR. And what Dr. Carson didn't mention in his book is that neurosurgeons use microscopes to be able to operate. And that means you have to be able to visualize things, sometimes in 3D. Things change direction very quickly under the microscope, and you have to be able to, it's a bit of a gift that, like I said, wasn't necessarily mentioned in the book, and I hated every moment of it. And I thought, oh no, all this time I was dedicated to becoming a neurosurgeon, and I can't even tolerate being in one surgery. The idea of neurosurgery was much more fascinating to me than the actual practice. So I was very confused for a little while. And in fact, at my medical school, the Department of Neurology, all but one person had upped and gone to another medical center nearby. And so there wasn't even the opportunity at that time during a neurology rotation in your medical school clerkships. It was optional. So I came home. I'm from Arizona, and I worked a rotation. I worked out to doing a rotation at Mayo Clinic here, and worked with some neurologists and said, now this is more my speed. And I fell in love with the idea of being able to talk with a patient and examine them and be able to start to put the story together of what was happening within their central and peripheral nervous system, and then line that up with an MRI and confirm what you might suspect. And then as I got into residency and working in the different specialties, I realized that for me, neuro-oncology really represented the best of what medicine has to offer. I love the idea of multiple varied specialties, a diversity of specialties coming together with a patient right at the center. And I feel like that's the way that we are meant to practice. And so every day I get to work with the neurosurgeons on the other side of the curtain, so to speak, outside of the OR, with the pathologists and the radiologists and the radiation oncologists. And for me, that's what's been so fulfilling. We've seen some breakthroughs in the time that I've been in practice, but there's so much more that's needed for brain cancers because these are devastating diseases for patients and their families. And so I spend my sort of research efforts towards making sure that patients have the highest quality of life that they can while we're giving them these in many cases, very toxic treatments. And then also in the more recent years, I've spent quite a bit of time on really trying to implement what looks like inclusive cancer care, because we recognize when patients feel like they belong and they're included within the environments, we know the rest follows in terms of adherence to treatment and outcomes and enrollment in clinical trials, some of the work that you all are doing that is so important, which is how we really move the science forward. And then I also, kind of an unsung gift of my career evolution has been participating in administration and recognizing that having representation at the highest levels within healthcare is at the level where policies are created, where we talk about things like access, making sure that we're not putting in any barriers that are leaving anyone behind. And so that's how I got to where I am today. And as I said, thank you again for the invitation.
I love it. You are speaking my language, honey. We could talk a whole show about that, even though that's not what we're here for today. But, so many amazing things and amazing points that you said within that. Now, my neurosurgery hopes lasted about 2 weeks. So I also read Gifted Hands, and I was like, yeah, I'm going to be a neurosurgeon. And then I, kind of calculated how long it was going to take. And I was like, yeah, okay, well, let's see if we can find something adjacent. So, so I'm glad you lasted as long as you did. I didn't even last 2 weeks after I read that book. So, everybody winds up where they're supposed to. I always say if everybody does that thing that makes their eyes light up, then everything is covered. So, it's amazing to have you two wonderfully brilliant and gifted ladies with us today. So let's talk about this haywire immune system, right? So, there are lots of, particularly since the pandemic, there are lots of things floating around about how's my immune system? I need to boost my immune system. Am I immune suppressed, et cetera, et cetera. But in these specialties, we really do deal with folks who are immune suppressed to some extent because of the treatments that we give. But let's talk about what happens when the immune system dysfunctions. And I want first, for you to describe kind of that dysfunction. Dr. Thierry, I want you to describe that dysfunction as it pertains to autoimmune disease. And then, you, Alex, as it pertains to oncology, because I kind of think of the immune system broadly as having a couple of functions. One of them is to make sure we can fight viruses and bacteria and recognize them, when they enter the body and make sure that we clear those out. Another major function is to, stop things from growing out of control, right? If we see something that looks like it might become a cancer, we want the immune system to kind of clean that up and stop that process. But what happens when that process goes wrong in terms of, from a neurologic standpoint? We'll start with you, Thierry.
Yeah. So, I just simply say the immune system is a very, very specialized system that has multiple functions. So I think Dr. William mentioned some of them already. It helps to fight against anything that's foreign to us, and that could be infection. It helps to fight cancer cells. So if there's something that's growing that shouldn't be there, the immune system can help to, fight that or break that or destroy that. There's a lot of other roles that the immune system plays, a lot of which manifests with inflammation. It tries to do different things that can help keep us safe and keep us healthy. Sometimes that system breaks down, and we don't clearly understand how that breakdown happens. But for instance, in autoimmune diseases, the immune system starts to pick on whether it's a protein or something that's part of our body, and the immune system just starts to attack it as if this is something foreign and it needs to destroy that thing. So for instance, in MS, the immune system picks on the fatty layer that surrounds our nerves in the brain and in the spinal cord. And it's almost like, okay, this is maybe some infection that we need to fight. And the immune system gets very sensitized, starts to attack it, starts to recruit cells to try to cause a lot of destruction to that fatty layer called myelin. And what happens is that myelin is stripped away, and that causes a lot of neurological symptoms, a lot of damage to the nerves, and long-term can cause a lot of a degenerative disease that leads to a lot of disability. That is very important of what's happening. Now, with every autoimmune disease, it's a different process. Like some people have lupus. The immune system gets sensitized against, connective tissues and joints and starts to attack it in that way. Arthritis, the immune system gets sensitized against joints and, starts to attack the joints. And so this very complex immune system that we've developed and have evolved over the years sometimes loses its tolerance for what is part of us. And, it should not fight what is part of us, but then it starts to, in some way, attack something that's part of us that it should be protecting. And so that's kind of how, in just very simple terms, how autoimmune disease happens. there are multiple different types of autoimmune diseases. I think the biggest question I get whenever I tell a patient, you have MS or you have, other types of, autoimmune diseases is, why did I get this? Like, what
Right.
caused this? Did I do something wrong? Did I get it from my parents? Did I inherit this? And the simple answer is there's no one thing that causes any of these conditions. It's just a complex web of different scenarios coming in a perfect storm. So there may be a slight genetic predisposition, you get from your family, but that's not all of it. There may be an environmental aspect that comes by, the environment or certain things in the environment. And then there's this just dysregulation of the immune system that we don't clearly understand why it happens, but it happens. And then once it happens, these are chronic diseases that have to be treated for the most part for the rest of a person's life. We don't have, for the most diseases, we don't have a cure that could just completely eliminate that disease and, take you to a place that you don't have that disease anymore. So I kind of go over that simple aspect of, the autoimmune diseases, how that happens, and, how the immune system can become dysregulated in some way. And rather than protecting us and taking care of us, it somehow starts to fight us, in a way that is very specific and targeted. And sometimes people have multiple. I've had people with MS and lupus or, other types of diseases that kind of come together in that way.
Mm-hmm. Thank you for that explanation. That's so clear. I usually say your immune system is doing the most. All right. And we want it to do less. Right. So it's doing the stuff it's supposed to do, plus extra stuff it's not supposed to do. And another way our immune system does the most is when people develop cancer. So tell us a little bit about that, Dr. Humphrey.
Yeah. So it was so beautifully stated that our immune system is looking for those foreign bodies to get rid of so that they never take host in our bodies and grow uncontrollably. And so we know that the way that cancer continues to thrive is it outsmarts that immune system. And so what gets really complicated with what I do in brain cancer specifically is not only are we dealing with our own immune system, but then the tumor itself, the cancer itself, can create its own immune microenvironment. And that's where a lot of the challenges come into play as we're looking at different options for treatment, and where unfortunately we've not made as much progress within brain cancers like glioblastoma as we have in other diseases like melanoma, where we find that immunotherapy, and I know we'll have an opportunity to get into that a little bit more, modifying the immune system in that way can be an effective treatment for the cancer. And unfortunately, when it comes to cancers like glioblastoma, because of the immune microenvironment that it creates within itself, it's an interesting target scientifically, but what actually happens in the day-to-day in the clinic is that we're finding we're not as effective at managing that microenvironment as we'd like. And so it continues to be a challenge. I'll say that way back, we used to think, oh, there's no immune system that's impacting the brain because of this thing called the blood-brain barrier. And we need that.
Yep.
It's important.
I was going there. You were reading my mind.
Yeah, but that's also one of the things that really challenges us when we talk about how do we impact the immunity within the neural tissues themselves, and what makes this area so complex.
Mm-hmm. Yeah. And that's actually one of the things that we are really struggling with now in MS, right? Because we have a really good way of treating, and that's not the topic of tonight, but since we're talking about it, we have a really good way of treating, inflammation that happens in the periphery, right? In the bloodstream, we've got plenty of drugs that target there. But there is this thought that when people have progression of disease where they just slowly worsen over time, that it's really inflammation that's happening compartmentalized in the brain. And so how do we get at that? How do we treat that? How do we target that? Because the brain is protected for a reason. We don't want everything that's floating around in the blood to get in the brain. But at the same time, if there's a problem, we need to be able to get therapy or treatment to the brain. So, it's a pro and a con, of the brain, but certainly something that, is a challenge to us in autoimmune disease as well. So let's just talk a little bit about some of the types of, neurologic cancers that you deal with or that you treat. Many people are familiar with breast cancer, prostate cancer, et cetera. But what are some of the common forms of neurologic cancer that, you encounter in your practice?
Yeah, thank you. So the bread and butter of what I take care of every day are what are called primary brain cancers. So that means a cancer that starts within the brain or the nervous system itself and then continues to grow there. And so, what I do, generally speaking, is very, very rare because brain cancers, primary brain cancers, they still are considered very rare diseases. Which much more common is something called secondary brain cancers, also known as brain metastases. So those are happening on a scale of about 10 to 1 compared to primary brain tumors. And that's when you have something like, as you mentioned, breast cancer or lung cancer that then travels and lodges within the brain or starts to grow within the brain itself. So that's a much more common form of brain cancer. But my particular expertise are in those primary brain tumors. So you've probably heard of something called glioblastoma. That's the one that tends to make the most headlines. It is a nearly universally fatal cancer, unfortunately, and it can take lives anywhere from a couple of months to a couple of years. And one of the challenges with brain cancer in and of itself is that in order to treat it, you have to start with a really good surgery. And that means you need to take it out and maybe take it out with some margin, some space around it. And we don't have that luxury in the brain to always take out a cancer with space around it because of the critical structures that are so close together. And so that ends up being one of the first challenges with what I do for patients with malignant brain tumors or tumors like glioblastoma. But the most common brain tumor would be something called a meningioma. And that's something that's totally benign, usually found because someone might have tripped and fell or had a car accident or something like that and ended up having a CAT scan or an MRI. And then they found this thing on the imaging and a patient is terrified because they're told you have a brain tumor. And so that's what ends up being a very common occurrence in my clinic. And so sometimes these benign tumors can grow quite large and they can cause symptoms. And in that case, yes, they need to be taken out. But the ones that are found just by accident, we call those incidental findings. Oftentimes they can just be monitored over time. And so there's a real range in what I see and what's considered a neurological cancer. But certainly not all of those tumors or cancers are created equal. And so important to be able to see a specialist to help sometimes make those differentiations.
Absolutely, because I cannot say how many people have come to see me and say, I've got a brain tumor. And I'm like, well, I think that's a meningioma. It's probably looked the same as it did 20 years ago when you had the last scan. Or people also have pituitary tumors, microadenomas or adenomas. So again, it's important to have that expertise, and to see someone who has that expertise. Don't just go reading your MRI reports and scare yourself to death on Google. Go see a specialist and make sure that you get the correct diagnosis. So tell us about some other common autoimmune, CNS conditions. So Dr. Guyan, you talked about MS and other related disorder. What are some of those other related disorders that you may see in the autoimmune space?
Sure. Yeah. So there are a few other diseases that I always call them maybe sisters or cousins of MS. So these are, we also call them demyelinating diseases, meaning it's a very similar, they do very similar, there's a similar pattern we see with MS where they're stripping out that myelin from the cells. So a few others that we have, other than MS, we have one that's called NMO spectrum disease, neuromyelitis optica spectrum disease. It used to be thought to be MS, but within the last maybe 20 years, realized this is a completely different disease. There's an antibody. There's a specific antibody called the aquaporin 4 antibody that we test in blood, and we see that people with this condition have this antibody. Presents a little similar to MS, where people have optic neuritis, very, very severe attacks of optic neuritis, and the spinal cord, transverse myelitis, and sometimes it happens in the brain as well. For the longest time, we thought there's a cell type of MS that's a little bit different, but More recently, it's been discovered that this is a completely different disease, completely different treatments. We don't want to mistake one for another because, the treatments sometimes can clash. So that's another one. It's not as common as MS, but I have a good enough. I feel like people say these are not common, but to me, they're very common because that's all I see all the time. So there's one that definitely don't miss as MS. And then more recently, there's another one called MOG antibody disease, another special blood test that shows us this specific antibody against a specific protein in the myelin. And that also presents in very different ways. It may look like MS, it may mimic MS, but when we do more testing, when we look at the spinal fluid and we look at the blood, we see that some of those markers are a little bit different and it's treated a little bit different from MS. So these are very closely related to MS, maybe sisters or cousins of MS. And then we also have other conditions that are autoimmune diseases and affect the brain, but are not necessarily the demyelinating type of diseases. For instance, we have things like autoimmune encephalitis, meaning there's some kind of, sometimes an antibody for a specific part of your brain that the immune system starts to pick on. And then people present with confusion, seizures, all sorts of, different neurologic symptoms. And we test the blood, we test the spinal fluid, and we find these unique antibodies. We treat that very differently than we would treat something like MS. And then we also have, I would say, systemic autoimmune diseases, like, for instance, lupus, or another condition called sarcoidosis, where the inflammation can find its way into the brain, right? So a lot of times the brain is very, very protected from the rest of the body, and we don't really have stuff getting into the brain in any way. But in some cases, I've had lupus patients where the lupus systemic inflammation finds its way in the brain, and the patient kind of comes, they're in the emergency room. We're always, trying to figure out what's going on. A lot of times we're testing the spinal fluid, we're testing the blood, we're doing a lot of, images to try to figure out what's going on so that we can give the appropriate treatment to these patients. And then finally, I'll add one other thing. Sometimes it's not the brain that's inflamed, it's the blood vessels of the brain. So that is called vasculitis. So those blood vessels that supply blood, oxygen, nutrients to the brain can become the target of the immune system. And when the immune system starts to attack them, sometimes the blood vessels close up, there's no blood supply, we see multiple strokes, we just see all sorts of very bad things happening when those blood vessels attack inflammation. And again, we have to do special tests, special, investigation to figure out what's going on, and then target treatments based on specifically what the immune system is doing. Is it attacking the brain? Is it attacking the blood vessels in the brain? Is it attacking specific antibodies or specific, pathways within the brain that we can identify? Because having that diagnosis is helpful in coming up with a treatment plan. Sometimes we have to do a brain biopsy because we just can't figure it out. All the tests, we do all the investigation, like, we don't know what's going on. So we have to call on the neurosurgeons and ask them, can you just take a little piece of that brain? And we take it to the pathologist, and they look at it under the microscope, and they give us a very detailed report of what they see going on, what type of inflammation is going on. And, Dr. Porter was talking about cancer. I've had some patients where we thought they had inflammation, and it comes back that they have some kind of cancer, for instance, like a lymphoma. Sometimes it can look like MS, it can look like inflammation, but the pathology comes back and is like, this is actually some kind of malignancy. And so we, call the neuro-oncologist, and we're like, let's come up with a plan for our patient so that we have a good treatment plan.
Absolutely. And sometimes it's the opposite, right? We used to call NMOSD tumefactive MS, because people looked like they had tumors and their MRIs were very frightening. And we would send them for a biopsy and it was demyelination. So, I think, it's very fascinating, this overlap, with, disorders of inflammation or immune dysfunction in the CNS. So there was one that you mentioned, paraneoplastic syndrome. So I think this one is very interesting because it's an overlap between oncology and it's actually neurologic symptoms that are caused by cancer, usually not a primary brain cancer. But I will never forget a patient when I was in my residency training. And this woman, we did every test on this woman and could not figure out what was going on with her. She was having seizures. She was just completely not responsive, was previously a very functional woman taking care of her kids. And I mean, we used to call on service, so I was on service like a month, and literally that whole month, we couldn't figure out what was wrong with her. And it was right at the time we had a neuro-oncologist, Dr. Voloshin, who's at Emory, and they had just started sending out these antibodies to this Professor Dalmau at, Mayo or wherever he was. And literally they found that she had an ovarian tumor. And it was so small. Like, we had done all the scans, they found this tumor. And that lady came to grand rounds about 3 months later and was completely normal. I never seen anything anything as close to a miracle like what you see on ER and all those medical shows. That was as close to a miracle as I've ever seen, because we could not figure out what was going on with her. So let's talk about that process, like what's happening, that there's that crossover, making those immune symptoms appear from a cancer that could be related somewhere totally different.
Yeah, I mean, this is another big area of, I do a lot of this with the oncologist and we collaborate on a lot of our patients, but in very simple terms, what happens is when there is a cancer somewhere in the body, like you talked about an ovarian teratoma, like an ovarian tumor, there's a few things that happen, we're still understanding, but your immune system picks up on something in that cancer and starts to fight it some way. And sometimes there's an overlap between some of those antigens or some of those proteins in the cancer, some of proteins in the brain. And so while your immune system is doing its job by fighting cancer, things that shouldn't be there, there's it's called molecular mimicry, where the molecules look similar to other molecules in the brain. And those antibodies, while they're fighting the tumor, the cancer, will inevitably attack the brain because those antigens, proteins are present in the brain as well. And so, what you described very classically called NMDA encephalitis, I'm sure, it sounds like if it was an ovarian tumor, it's most likely NMDA encephalitis, where, the tumor, they tested the tumors and they have this receptor that is also found in the brain. And so your immune system is just doing its job by trying to fight the tumor, but because of that similarity between the proteins in the tumor and the brain gets hit, and typically these patients don't get better until you take out that tumor. This has been described with many other cancers. These are called paraneoplastic syndromes, meaning, there's a remote cancer in a completely different part of the body, not in the nervous system. The immune system picks up on it, and because it picks up on it, it starts to produce some antibodies or some, markers to fight that cancer. Those antibodies attack the brain as well, or attack, in some cases, the spinal cord. In some cases, it attacks the receptors on the muscles. Like there's a condition called Lambert-Eaton myasthenic syndrome, where it's kind of the receptors on the muscle get hit. For the most part, with some of these conditions, once we see that marker, we know there's a tumor. Some of these antibodies are very high risk that there's obviously a tumor somewhere, and we just start looking for the tumor while we're treating the patient. With the classic example you provided, NMD encephalitis, about 30% of patients will have an ovarian tumor. The rest of them will not have any tumor, and I usually would monitor them even after treated and you're feeling better, like a year later, I'll just, check for tumor just in case it was a very small tumor. But we're seeing a growth in these conditions, finding out more and more about these conditions. Maybe we'll talk a little bit, I don't know if Dr. Porter is going to talk about some really cool drugs called checkpoint inhibitors that can increase the risk that these Paraneoplastic syndrome happen because they in some way try to heighten your immune system to fight tumors. But once we do that to fight the tumors, we can also have antibodies fight in the brain, fight in the spinal cord, fight in the muscles. And so it's just a big field right now with lots of new things coming out all the time where, tumors can trigger the immune system to fight the brain or fight the spinal cord. And at the same time, some of the newly specialized treatments that we use for cancer, called checkpoint inhibitors, can in some way increase the risk that we develop some of these, unusual antibodies, that can happen while you're fighting cancer and also can overlap with fighting the brain.
Mm-hmm. That was an eloquent explanation, Terry. It just gives me such an appreciation for the balance of our bodies and our functions. When one thing goes haywire, you can see how many downstream effects can happen, but it just gives you such an appreciation for when things are working like they're supposed to. Like, gosh, all of these things have to balance each other so that, I can get up and do the things that I want to do, or, it's just, I know that I'm in the right field because I'm completely fascinated, and I'm sure somebody somewhere is taking a nap. But I'm totally enthralled in this conversation. But going back to treatments, so I want to start talking a little bit about treatment. So oftentimes when we are treating autoimmune conditions, when we are treating, cancer, we use what we call immune suppressants. But we use them in different degrees. So let's talk about, I want you to start, Alex, a little bit about when you are trying to treat, a cancer, what is the goal of treating with that suppressant therapy, or what are the types of therapy that you use, and kind of what are you trying to accomplish or achieve with the immune system with that therapy?
Yeah. It's an important question, and one that I hope I'll have an even better answer for in the next few years. But I'll tell you today, the mainstay of treatment for the most aggressive malignant brain tumor, glioblastoma, is a combination of cytotoxic chemotherapy, so really working on the DNA of the cancer itself, and radiation therapy. There have been a lot of clinical trials that have looked into answering the question, does modifying the immune system, either at the time of newly diagnosed glioblastoma or at the time that it starts to outsmart our treatment and grows back, which is the time called recurrent glioblastoma, is there a role for immunotherapy at either of those 2 points in this disease? And so far, the clinical trials have all been negative, which has been really disheartening for all of us in the field, because we've seen the success, as I mentioned earlier, in cancers like melanoma, where people may have numerous brain metastases or cancer deposits in the brain from their melanoma. They use these different immunotherapy medications and potentially are cured. You see an MRI that looks totally normal after receiving these drugs, and we just haven't made that same level of progress when it comes to glioblastoma. So I mentioned newly diagnosed, which is the first time that this cancer has been identified, and then recurrence. So there is one treatment that has been approved by the FDA in recurrence. It's not a classic immunotherapy, but it's a medicine called bevacizumab, and it's an antibody to something called VEGF, vascular endothelial growth factor. And we know that when there's inflammation, that the VEGF works to help the tumor grow its own blood supply and fortify its own blood supply so it continues to grow. And when there's inflammation, this VEGF gets more highly expressed on the blood vessels that are part of the tumor. And so this medicine, bevacizumab, an antibody to that VEGF, has been approved by the FDA in the recurrent glioblastoma setting because we found that it increases what's called progression-free survival. So it helps patients live a bit better, live with a higher quality of life. But what it hasn't shown us is that it can improve overall survival. So you might have a longer time of where the cancer is relatively quiet, but then unfortunately it outsmarts us again and grows in spite of the therapy that we had just been given. And so it's like I said at the beginning of my answer, I hope, Mitzi, that if you ask me this question a couple of years from now, even next year, I hope I could tell you that there's been a new breakthrough and we found the right time and space to modify the immune system. I think that for a long time, we treated glioblastoma with just radiation. And then around 2005 is when temozolomide, that's the oral cytotoxic chemotherapy that was added to that regimen. And then some years later, we learned more about bevacizumab, and there's something that's called tumor treating fields, which is not even a medicine in itself. It's a device that looks like it has some efficacy. And so it seems every few years, every decade, we have a breakthrough. And really in this last decade, I'll tell you that the biggest breakthrough we've had with primary brain cancers is understanding all of the molecular differences and how what looks like glioblastoma really has a range of molecular expression. And what I hope to see within my career time is when we can practice individualized medicine, where patients are eating a combination of things based on what we've learned about the nuances of their individual tumors. And I suspect that's going to be where we start to see the role of modifying the immune system, whether it's through a pill or an infusion or directly into the cancer itself. There's vaccine therapies that are stimulating the immune system, still under clinical trial, not yet approved for routine use by the FDA. But I hope to see that within my career time, because I think that's where the field needs to go. And unfortunately, right now, what's the saying? If all you have is a hammer, everything becomes a nail. And we know that's not the right way to treat these cancers.
Right.
Because it's such a rare disease and it's hard to get the clinical trials done, we just haven't made that same level of progress as our other friends who take care of patients with breast cancer and lung cancer and kidney cancer.
I think one of the reasons I went into neurology is that I always felt like it would be the cutting edge of medicine. I mean, just the fact that there are these new discoveries, even if it's every decade. We had, a long period in neuroimmunology where there was nothing we could do. And then all of a sudden now there are like 25 things we could do.
Right.
Like literally feels like overnight. But I think, that is one of the, the things that's very encouraging to me is that everything is not, it's difficult, but it also is, exciting that everything is not figured out down to the, to the last receptor. And there's just so much room for discovery and so much room to improve the lives of the people that, we get to serve and we get to treat every day. So, I'm looking forward to that talk, when you tell us about that next advance. I think one of the things that I wanted to address in thinking about immunosuppression is that with many of our therapies, we are trying to decrease the immune response to some degree. Typically with our autoimmune inflammatory diseases, we are giving drugs that modify or suppress the immune system, but usually not to the same degree as would be given like in the oncology space, maybe more so for those who have cancers that have spread to the brain or spread to the CNS. We're really not trying to completely wipe the system out. We're just trying to knock it down a little bit so you can go around and do your daily activities, but still be able to function. And so I like to try to make that distinction because sometimes our therapies overlap. So there are treatments that we use that are chemotherapy, right, and have been used for cancers. And so I think making that distinction to our patients is extremely important, like the way that we use the medicine, the doses that we use the medicine. Sometimes we don't give it in the same way, that is given for other conditions, just so that people, recognize they don't necessarily have to walk around in a bubble, and those type of things. Are there any things that you kind of offer to your patients, Dr. Gang, when talking about immunosuppressive therapies and they're concerned? I had one that I was talking to the other day, and she's like, I'm really scared of this drug. It's going to suppress my immune system. I was like, that's the point. That is the whole point of me giving it. Like, that's what I wanted to do. She was like, I'm scared. I was like, no. That's the goal. So what kind of advice or words do you give to your patients when they hear the words chemotherapy or get concerned? What do you say?
Yeah, I mean, in general, there's always a concern if you hear that a medication we're giving you could cause potential side effects. A lot of times what I try to do is balance those risks with the patient. For instance, I would say, okay, if you're young, you're healthy, we're giving you this medication. Okay, I'm going to tell you about the risks, but honestly, the risk of you, or the chance of you getting something that's catastrophic with any of these medications and becoming, significantly disabled is very, very little. The risk of not treating MS over decades, I mean, disability, like that risk is this high, like it's much higher. But sometimes when we just mention, okay, there's a potential that you get a brain infection with this drug, people are just completely zoned out. And it's like, I'm not going to do it. But I'm like, well, you're not balancing that with a risk of not treating your MS appropriately. And, we don't just put you on a medication and send you home. We're constantly monitoring you. We're constantly, seeing you in the clinic, checking your blood, making sure that, we're not overdoing things. If, you're having more infections, we're going to ease back on some of the treatments. You mentioned cancer. I have some of my patients that, have been diagnosed with cancer. I talk with the oncologist. Sometimes I will hold off on the MS treatment while we take care of cancer, because the cancer treatments have very strong immunosuppressive effects. And so everybody's different, but I think sometimes people don't balance risks, because once the doctor says there's a potential for something happen, like we have to tell you the risks. But for the most part, sometimes I feel like when I say that, people feel I just have hundreds of patients, with PML or some, they feel like the risks are very significant. The risks are real, meaning they could happen. But for the most part, with a lot of these drugs in a young, healthy person, the risks are very, very low. But the risk of not treating MS for a long time is disability. And that disability happens very slowly. I always talk to my young patients about, I also see older patients that have not treated their MS appropriately. And they always say, I just wish I had the opportunity of having medications when I was 20, when I was 30. Because they've become so disabled because they didn't have the opportunity to have these really specialized treatments. And then some people this age are like, well, no, you said I could get something from this drug and I don't want to do it. And I sometimes wish I could have people meet and talk to each other, and you could see what happens in 20 years and 30 years if that MS is not appropriately treated. So I usually would balance risks and just give you the counterpart of, this is a potential risk with the medication. It's an extreme, I'll give you the realistic aspect of how high that risk is, but put that side by side with what is the risk of doing nothing or not appropriately MS. It's a slow evolving disease, but in a decade or in 20 years, you may be in a wheelchair, whereas you may have been on the medication and be completely fine and you never had any of those risks. So I think it's just balancing them out and reassessing the risk at every point. Sometimes the patient gets older, they're having UTIs, and I say, okay, it's time to back off. Let's back off on this very potent treatment. I don't think you need it anymore. And so just knowing that it's not a lifelong decision, we could change, we could modify things, but the ultimate goal has to be very adequately treating MS, and then we keep reassessing that risk.
Yeah. It really goes back to quality of life, right? We all want our patients to have a great quality of life. And I love what you talked about, Alex, earlier about that multidisciplinary team approach. We try to do that in autoimmune disease. In some cases, we're a little more successful than others, but I think that you guys in oncology really have it down that communication between all the specialists involved and really putting that person in the center and trying to, create a treatment plan that's as personalized and as specialized as possible. So, we're aspiring to get there. A lot of us are there, but some of us, we still have a long way to go and kind of really bridging those gaps between the different members of the team. So the time has flown by, ladies. Listen, this has been an amazing topic. Like, I've learned so much from both of you, but I always like to ask at the end of every brain chat, what are you excited about in the field? So I'll start with you, Alex.
Yeah, I mentioned that about every decade we end up having maybe a new drug or something new to offer. And in the case of, so there's, if you think about brain cancers as a whole, the umbrella that we put them all under is glioma. And something like glioblastoma would be considered a high-grade glioma. And then there are lower grade gliomas. Usually these are grade 2 tumors. Glioblastoma would be considered a grade 4. Well, just a few days ago, on August 6th, the FDA approved for the very first time a drug for low-grade glioma. So if patients have a grade 2 astrocytoma or a grade 2 oligodendroglioma, we finally have something to give to them. And the drug is called vorasidenib, and it's an IDH inhibitor. And we learned a lot from our colleagues in multiple myeloma who've been using this class of drugs for quite some time. But we found in low-grade glioma, using a daily oral medicine, this vorasidenib at 40 milligrams per day, it improved the progression-free survival, so time to when we start to see the low-grade glioma start to upregulate itself, and also improved time to next intervention, meaning there are people that have started on this medication at their diagnosis and still, at the time of FDA approval, have not had growth of their cancer, albeit a lower grade cancer than what we talked about before in glioblastoma. So it's really exciting for patients with low-grade glioma because they tend to be younger and have a lot of life ahead of them. And until now, we were treating everyone with radiation. Sometimes we would use temozolomide, that cytotoxic chemotherapy that I mentioned earlier. And what's nice is now with this medicine that seems to have very few side effects, can be used for years safely, holding off those more toxic treatments for as long as we can. And so that's something that I'm really excited about. And the timing was just perfect for our talk today.
Awesome. That is great news. I've been doing my little silent clap over here. That is amazing. Amazing, amazing. All right, Thierry, what are you excited about?
I'm really excited about all the brain cancer stuff happening, and it gets me excited. With MS, I think there is a new way of thinking about treating MS in terms of trying to target those immune cells that are resident in the brain. So I think a lot of the newer treatments have looked at, can this drug actually penetrate into the brain and affect those resident immune cells in the brain? These are called microglial cells. And so I think one of the big studies that, some of the big studies that are going on right now, which we're going to be ending soon, and the results are the BTK inhibitors. And essentially, the big difference between these drugs and the drugs that we've used for, the longest time is these drugs actually penetrate into the brain and affect microglial cells. These are the immune cells resident in the brain. And the thought is, could doing that prevent the progressive aspect of MS? Could doing that become a neuroprotective mechanism to prevent more disability in the future? Because a lot of our medications are good inflammatory drugs. They shut down the immune system outside the brain, but they don't have a lot of neuroprotective effects or effects that directly affect the brain. And so I think, we will find out very soon if these BTK inhibitors will achieve that. The other big, thing that's happening is we're using these specialized cells used for cancer therapy called CAR T cells. There are studies ongoing right now to look at these specialized cells where they take out your cells, they engineer them in some way and engineer them to become, to attack, specific immune cells, and then they put those cells back in you. It's been used for cancer, leukemias, I think, or lymphomas. Right now, we are about to start studies looking at using these specialized cells for MS, and mainly, whether progressive MS, relapsing MS. That is, a lot of the studies are just starting in MS. I think they're starting in other autoimmune disorders like lupus. And, it'll be a few years for us to find out if these mechanisms provide a better advantage than doing something like a monoclonal antibody. So those are just a few things that are going on that I felt would be relevant to talk about.
Well, it is an exciting time to be a neurologist, if I do say so myself. Thank you, brilliant ladies, for just sharing your knowledge with our Brain Chat audience. I'm sure everybody will get, even more out of it than I did. I got so much out of it. And, thank you so much for your time. And thank you for the work that you do serving, and treating, people with chronic neurologic disease. Like, we really appreciate the amazing work that you all are doing to, help patients, but also to advance the science. So thank you guys for coming on Brain Chat. This has been a fantastic episode. And I will see everyone in 2 weeks' time. Have a great one, everybody.